Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. This is the audio version of the past week summaries, which this week were brought to you by our authors Ketan Patel, Vivian Leigh, Joshua Belford, Denrick Cooper, Kimiko Dunbar, and Clay Smith. Alright, let's get straight into the first article, which was titled Tranexamic Acid in Trauma, a Joint Position Statement and Resource Document of the NAEMSP, ACEP, and ACS-COT, whoever those other people are, out of the Journal Trauma and Acute Care Surgery. TXA is widely used, but has not been adopted in the pre-hospital setting in a lot of circumstances. And so we always want a little bit more data to be more precise on what's going on pre-hospital. We need to know long-term outcomes, how it fits in with transfusions, what are the complication rates if we're giving it pre-hospital. We need to know a lot of stuff. So, several emergency medicine organizations sought to answer a couple of questions for us about pre-hospital TXA. Is it safe and effective in suspected hemorrhagic shock? Can we identify patient populations who would benefit most? And then what about, system development, implementation? What are things we have to consider in that regard? Now, sadly, in order to do this sort of guideline update, they only searched PubMed and did not involve a medical librarian. Kind of a shame. You could have found more literature. Now, just like in the in-hospital setting, TXA can be life-saving if it's given early. A 40% reduction in 24-hour mortality when given pre-hospital. Although this was just from 4 studies, and largely it was just from one retrospective study. Less dramatic differences can be seen at shorter time points, and there's actually no benefit past 24 hours. Though data was a bit mixed, notably not so beneficial if you were also getting blood pre-hospital, then there was no real effect of TXA. At least on mortality, you were still giving less blood products to these patients overall. All the same, they still recommend pre-hospital TXA and preferably given within an hour of the trauma, which is going to be easiest if it's given pre-hospital. There does not seem to be enough data to give a clear recommendation on the dosing strategy, whether to give 2 grams all at once or give 1 gram and then another gram over 8 hours. Personally, I always thought that 2 grams made a lot more sense. 8 hours later, do I really need TXA running? If you've survived that long, I don't think TXA is what's going to be terribly helpful for you. There's even less data on what dose to give in the pediatric situation. Don't give it to everyone pre-hospital, though. Really try to stick with patients in hemorrhagic shock. Though it was quite safe, there was no clearly identified events of thromboembolic disease or seizures because of this TXA being given. And it also seems that there's currently no indication for this in isolated head trauma. If there's head trauma with all the other trauma, sure, of course. But if it's just head trauma, probably not giving TXA. If you want to have a more informed approach and combine TXA with viscoelastic testing, then you're going to have to study it more because that's also, we're just not able to really comment on it. So the consensus seems to be for pre-hospital use of TXA, give it early, preferably within an hour if you can, but don't just give it to everybody. Really reserve it for hemorrhagic shock patients. In a spoonful, if you have a robust EMS system, keep in mind that they could be starting TXA, and it would probably be beneficial for your patients, even if it only helps with mortality up to 24 hours. The data seems to be mostly in favor of this pre-hospital TXA, so it might be gaining traction. And then the second article, titled Increasing the Potassium Level in Patients at High Risk for Ventricular Arrhythmias, out of the New England Journal of Medicine. I absolutely adore the first sentence of this article. It was so funny. They said that there's a U-shaped relationship between potassium levels and death. Duh? How does this get past? Who writes this? It's an electrolyte or anything in the body. If there's too little of it or too much of it, then it's gonna relate to death. That's how homeostasis works. You always want to be in the Goldilocks zone. Of course, potassium's bad when it's too low and it's too high. Come on. But the authors think that perhaps lower is worse. It seems to be that there's a little bit of evidence that indicates that if you have a high to normal potassium in the range of 4.5 to 5 millimoles per liter, that's better because you're less likely to have an arrhythmia. Now, if you really wanted to test this, you would have to test it on patients who are prone for arrhythmias, ventricular arrhythmias specifically, because those are the dangerous type. And so that's exactly what this study did. It was called the podcast trial, and they recruited patients with ICDs. And you're not going to have an ICD unless you're at risk for a dangerous arrhythmia, so it's a great population to study. Not to mention, they have an implanted device which tells you if you have any arrhythmias. This is a great population. However, they make some kind of spurious connections and associations here. They say that mineralocorticoid receptor antagonists, we're thinking spironolactone, and ACE inhibitors, while they decrease death in heart failure, but they also increase potassium. So the authors think that it's probably due to the potassium. And while that's not crazy, I mean, it's possible, or that potassium might play some role, they're also really well-known heart failure drugs and have other mechanisms of action besides the potassium. Usually we think of the potassium as kind of a bothersome side effect. So they take these ICD patients, 1,200 of them, and they bump up their medications, their spironolactone or their ACE inhibitors, to increase purposefully their potassium levels, to try to get them in that 4.5 to 5 range. If they can't get them there with drugs, then they give them potassium supplementation. They base this off the fact that in low-sodium diets, if you substitute sodium for KCl, which is kind of a salty substitute, that those patients will also have higher potassium, and there seems to be a mortality benefit here. But all of their associations are kind of weird, because all of those have different mechanisms for why they would help in heart failure. Like lowering the sodium, I mean, like a low-sodium diet, right? It's a classic thing. So all of these have kind of weird, confounding to it. So it's going to be a bit of a messy trial, in my opinion, which, despite this being in the New England Journal of Medicine, they don't even address in their discussion or their introduction that there's this bi-mechanism here. Anyways, we'll talk about it in a second. But it is fair to say that if your potassium is low, you could be more prone to dysrhythmias. I'm thinking torsades in this circumstance. I mean, too high is, of course, bad, and they excluded patients who had, renal failure to a dangerous degree. So in patients who can clear the potassium, if their potassium is higher, would this be beneficial? Only a quarter of the patients actually received potassium supplementation, and the rest just had pharmacological measures. Now, the results of this were actually pretty good. There was a hazard ratio of 0.76. That was comparing 29% to 23% for their composite outcome of arrhythmia, heart failure, hospitalization, or death. This would give a number needed to treat of just 12 by just raising the potassium levels, which is actually pretty significant. If you're avoiding ventricular tachycardia, heart failure, hospitalizations, or death, these are important outcomes. And interestingly, it wasn't just one outcome that seemed to drive the composite outcome. They all seemed to increase a little bit, which is very positive. You don't see that for many trials. On the flip side, they didn't actually increase the potassium of these patients very much. The baseline was right around 4, and they didn't actually get it above 4.5. They got it closer to 4.3, 4.4. So they didn't actually reach the potassium levels that they were hoping for. And then they did not include a sub-analysis of patients that just got potassium supplementation. And that's probably the group that I'm most interested in, because that's the group that all you did was increase their potassium, instead of giving them heart failure medications when you have heart failure outcomes. So all of this is really interesting, but I think there's too much of a plausible alternate mechanism for this treatment effect. And that is really aggressive treatment of their heart failure. Don't forget, we actually covered an article a few months ago that showed that higher potassium levels were linked with in-hospital cardiac arrest. Now, these are outpatients, but all the same. And that same association was not associated with hypokalemia. And so I don't even know if we're on the right course here necessarily. So I'm not sure what to take from this exactly, but it seems like if you aggressively treat heart failure, then you get better heart failure outcomes. There may be some role to play here in that higher potassium levels are associated with less ventricular arrhythmias, but from this data, I really would not confidently say that. In a spoonful, I'm skeptical, but there may be a role to play for patients who are at risk of ventricular arrhythmias to have a higher baseline potassium level. So maybe this works, but I'd love to have seen that sub-analysis of patients that just got potassium supplementation that would have sold their point better than the other subgroupings. Okay, that's all the articles that we had to talk about this week. Let's do a quick wrap up of everything we learned. From the first article, Prehospital TXA is perhaps beneficial, but try not to double dose, so you're going to have to talk to your EMS specialists to see if they gave it first. If they can give it, then it's probably best they do give it. From the second article, I'm going to give a big maybe to that higher levels of potassium might decrease mortality in patients with ICDs. Now, if you are hearing this right now, then you are not a part of the members feed, and so you missed 3 articles from this past week. If you subscribe to be a member, you will hear more. What did you miss? Well, the PCARN C-spine injury rule might be applicable for application by EMS clinicians. And then we covered an article that tries to revive targeted temperature management by providing it with high quality. And then finally, a new PCARN rule for infants aged 61 to 90 days old. Links to all the original articles can be found at journalfeed.org or just follow the links in your show notes. Our goal here is for you to keep up the easy way through spoon feeding. Thank you.